In 2006, the King Edward VII Hospital up in Midhurst closed. We had a 12-bedded palliative care unit, and this service, purely in the community, has come about as a result of the closure.
We got the 6 surrounding PCTs together, and we sort of said, well, what do we want? And they all said, we want the community aspects of this. We do not need the beds.
We operate purely in patients' houses or in nursing homes. We offer interventions at home, so if patients require things like blood transfusions, doctors and nurses can go out there and administer all these interventions at home. The programme is funded 50% from the NHS and 50% funded by Macmillan Cancer Support. It's unusual for them to fund a service in this way, but when the hospital closed, they said they would continue to fund us if we did something innovative and new. Sarah, the next one's yours as well. We've got a multidisciplinary team. We've got just over 2 whole-time equivalents of consultant time here. We've got Sue and myself, job share the service lead. We've got about 6 clinical nurse specialists, about 5 other trained nurses and 4 support workers. We've got a physiotherapist, an occupational therapist.
So the aim of our clinical team is to provide that extra visit or do those treatments that would have been done in a unit. We don't replace what the district nurses or GPs are doing, but we provide that 2nd and 3rd visit perhaps in a day. That means that that patient can stay at home. We meet every morning just to go through the really sick patients and allocate all the new referrals that have come in that day, talk about probably any deaths that have perhaps happened overnight. Then the CNSs will ask the doctors about anybody that they're particularly worried about.
By his son lives literally opposite him. I have anywhere between about 40 and 60 patients. For the patients, I'm really like their link person to the service.
Depending on the patient's need, we decide then who's the best person to see them, whether they're seen by the clinical nurse specialist or maybe one of the doctors might see them if it's a very medical problem they've got. Part of my role as a doctor often is to see patients at home who are unable to get to hospital outpatients, and I can then liaise directly with the hospital consultants, and so the patient doesn't feel in a way sort of they've lost that contact.
The district nurse is going to go and have another look at it.
We've got about 70 volunteers. They can sit with patients, offer respite sits to enable carers to go out and have a bit of time off or go and do some shopping. Our volunteers do all our transport for our patients as well. They can take them for their daily radiotherapy or for hospital appointments. The Crosscare is our IT system here for holding all our patient data.
We've all got access to all the patient's notes, and then you can use it in a mobile capacity as well, so offline when you're out in the community.
It's a brilliant tool for auditing what we do. We can look up at a flash to see, ask it various questions and get an answer pretty quickly.
I think the key thing is communication, so communication within the team, but also more widely.
We work incredibly closely with our GPs and community nurses. We would recognise them and see them as the main people looking after the patients, with us advising them.
The clinical team work across, but they have got to know the community nursing teams. They always know who's on call for which one at the weekends. They do joint visits with them, they go to their meetings.
Ultimately, they're a team of dedicated professionals, all with the same goal in mind, which is to provide the best patient care.
Most of the time, she seems to be pretty well pain controlled.
We have a fairly non-hierarchical structure here, which I think helps people, and everybody's role is valued.
Flexibility seems to be another feature of our service. We don't have too many strict criteria about our roles.
All our staff are happy to go the extra mile, whoever is in the house at that time, and if the patient needs something, on the whole, the staff will get on and do it.
I think everybody just has the patient at the centre. We'll take time to find out what it is that is important to that patient and share it.
We do reduce the number of times that patients need to be admitted into hospital.
Whereas previously people might have had to go into hospital for a blood transfusion, they could now have it at home, which is quite innovative work. They get, I think, a lot more support in the community than they might otherwise get. We have time to spend with them.
Obviously there are unavoidable admissions into hospital and we look at those and monitor them very carefully, but they will be unavoidable on the whole. One of the main service objectives is for people to have choice of where they're going to be looked after and where ultimately they may die.
The preferred place of care is between 70 and 80%, if that's what we achieve.
We send out a bereavement questionnaire routinely. One of the fears was that would this type of model, looking after patients at home, put an extra burden on relatives looking after them. Although yes, it was hard work and emotionally difficult for them, they ultimately, when asked later after their relative's death, they were really pleased in hindsight that they did it.